Hello, my name is Megan Oleksiw. I'm a medical student and student researcher at the Montreal University Hospital Center, and I'm delighted to have the opportunity to discuss, on behalf of myself and my co-authors, our manuscript entitled Computer-Assisted Optical Diagnosis of Colorectal Polyps up to 10 millimeters, published in Endoscopy. For context, optical diagnosis consists of real-time polyp pathology prediction during colonoscopy, allowing certain polyps to not be sent to pathology and to rather be resected and discarded or diagnosed and left in place. These strategies are endorsed by gastroenterology societies on the condition that certain quality benchmarks can be met. Artificial intelligence-based computer-aided diagnosis, CADx for short, can classify polyps as neoplastic or hyperplastic in real time on the endoscopy monitor, and has shown promise in improving optical diagnosis performance, potentially helping its implementation. Our study aimed to assess diagnostic performance of optical diagnosis using CADx, either as an assistive or autonomous tool, for polyps measuring 1 to 3, 1 to 5, and 1 to 10 millimeters. We conducted this study to help determine the polyp size cutoffs up to which it would be safe to replace pathology when implementing CADx-based optical diagnosis. We thus performed a secondary analysis of a randomized controlled trial conducted at our center in which optical diagnosis with CADx use was systematically documented for polyps up to 10 millimeters. Our primary outcome was agreement of optical diagnosis-based surveillance intervals with pathology-based guidelines when size cutoffs of 3 millimeters, 5 millimeters, and 10 millimeters were used. Our study cohort consisted of 313 patients with 463 polyps. Surveillance interval agreement was above 90% with a 3 millimeter cutoff, but fell below 90% with a 5 millimeter and 10 millimeter cutoff, meaning that the ASGE PV1 90% surveillance interval agreement benchmark for resect-and-discard was only met when using a 3 millimeter size cutoff. Prevalence of advanced and serrated lesions significantly increased with polyp size. Interestingly, accuracy did not vary with polyp size and was rather low, between 72.5 and 76.6% across all size groups, irrespective of autonomous or assistive CADx use. In our cohort, this low overall accuracy was driven by overdiagnosis of C-cell serrated lesions. Lastly, rectosigmoid negative predictive value exceeded the 90% ASGE PV2 threshold for diagnose-and-leave for optical diagnosis up to 10 millimeters. In conclusion, our study found that using CADx-assisted optical diagnosis met quality benchmarks for resect-and-discard only when a 3 millimeter size cutoff was used. The decrease in surveillance interval agreement when expanding beyond 3 millimeters seems to be due to increased prevalence of advanced and serrated lesions in larger polyps rather than a change in overall accuracy. These lesions are notoriously challenging to identify optically for both endoscopist and CADx. However, it is these lesions that most strongly influence patient surveillance intervals. Hence, our study highlights the need for improving identification of these advanced adenomas and C-cell serrated lesions, which currently present a challenge for optical diagnosis implementation at a 5 millimeter cutoff or beyond. Thank you very much.